Thank you, Paul. All right, since you're advancing my slides, we'll see how this works. These are my disclosures. None of them are relevant to this talk. So the overview, what we're going to be talking about today is going over a little bit the pathology of dissection. We'll talk about how we define them, the importance of vascular complications that occur. And then I really want to focus on the current indications and clinical reasons why we would intervene. I'm going to talk about medical therapy and endovascular and go through some of the work that we've done looking at natural history of both. Forward. All right, so some statistics. It's a rare disease, 14 to 20 per million per year. About 33% of them are type B dissections, and they account for 43 to 47,000 deaths a year. And branch vessel compromise occurs about 30% of the time. When you're looking at presentation, the majority of patients will present with pain. About 85% will say that it's abrupt onset. We always say that a type A dissection will be chest pain and a type B might be back pain, but it really doesn't matter. Often it's an atypical chest pain that they'll have. But almost all of them say it's the worst pain ever, and they all knew there was something wrong, and it made them come to the ER, even people that rarely go. Most of them will be hypertensive. They'll have neurologic symptoms, and some will have peripheral vascular symptoms. So the thing to take home from the presentation is if you have a young hypertensive patient with chest pain and they don't have an MI, get a CAT scan. Don't do other things to rule out PE, because the CAT scan will rule out everything for you and it'll help you identify the dissection. We classify them. It was originally classified by DeBakey. We now use the Stanford classification, where a type A, the entry tear is in the ascending aorta, and a type B is distal to the left subclavian. So click once. You'll see that the type A mortality is very high with medical management, so this is a surgical emergency. So if you treat them medically, about the death rate can be up to 64%, whereas surgery does better. Click again. Type B, traditional open surgery had very high mortality rates, and so the standard treatment for type B is with medical therapy. Next. So that's location of entry tear. When we look at timing of presentation, we define them as acute or chronic, and the traditional definition is acute is within 14 days, and this is because most of the major complications occur within that time. There is some change there where now we're talking about a subacute topic where it goes up to about 3 months, and part of that has to do with treatment because the entry tear or the dissection flap is still malleable at that time, and so you can still treat them. We also look at symptoms where a complicated patient is one that has a presence of end organ ischemia, or they can have malperfusion, refractory hypertension, that type of thing, and an uncomplicated would be an asymptomatic patient. Next. So the IRAD study group is a group of hospitals around the world that treat dissections, and this was a study that they put out. I call it turn of the century now because it's getting older, but it was 18 academic centers. They had 400 patients, and the thing to take home from this click is that 73% of the patients were treated medically, and this is because, if you click again, there's a 32% mortality with surgery, and the medical mortality was only 10%. Next. So why is that? Well, when you think of the anatomy of a dissection, in the ascending aorta, the concern is that it could rupture, and the concern is that it could get into the coronaries and cause an MI. But in the descending, in the type Bs, rupture is very rare unless you already have an aneurysm there. And so this is the reason why medical therapy works, and it's that you're really trying to just prevent branch compromise and prevent the event from getting worse, and so that and with open therapy having, or open surgery having a high mortality rate, that's why we went to medical therapy. Next. So what happens? You get the initial tear, and then with each heartbeat, you get a surge of blood that goes down and basically continues to rip the layers apart. And then you'll develop fenestrations that will keep things patent, and they'll be the reentry foci. Next. All right, but as greater amounts of the aortic circumference is involved, you'll see that there is pressure from the adventitiously bound false lumen pushes on the true lumen. And so when you look at these on a CAT scan, it's actually the true lumen that is smaller than the false as it's pushing in there. And this can lead to compromise in blood flow. Next. And this is just a picture of it. This is a patient where the true lumen is actually completely dissociated. You can see this is the true lumen there, and it's sort of the Valentine effect there. If you go to the next one, as you look down into the visceral segment, what you're seeing there is the origin of the celiac, and the true lumen is actually this little nothing there. And so the true lumen is completely compromised because it's been taken off there, and this is how you get the branch vessel compromised. Next. So there's two types of obstruction. What you're seeing there is what's called dynamic obstruction. What's happening there is the bulging from the pressurized lumen acts as a flap, and so with every heartbeat, it obstructs the flow to the end organ. Next one. And then there's a static obstruction that occurs where you actually have the dissecting process or the intimal flap extending into the artery, and so then you have thrombosis or lack of flow on that side. And so those are the two things you have to figure out. And next. This is actually a dissection here. You can see that there's intima all grouped together. Next one. And there's actually a static obstruction there where the renal artery is, there's no flow there. And if you look at the next one, when you look at a CAT scan, you can see on this nephrogram that there's clearly on the right kidney on your left has flow in it, and the left kidney on your right doesn't. And so you can see the difference there, and that's how one way that you can tell that there's going to be compromise there if the patient doesn't have a problem yet. Next. Okay, so, and click again. So this was work done by Dr. Cambria when I was in high school, but essentially what he found was that branch vessel compromise is a problem. If you see on the top there, if the patients ruptured, it didn't matter, everybody died. But in the patients that didn't rupture on the bottom, if they had branch vessel compromise, there was a 45% mortality at 30 days, and if they didn't, there was a 17%. So it's important to identify these. Next. So, treatment principles, basically prompt medical therapy, identifying these in the patients in the ER, looking for malperfusion early and treating it if necessary. And the question becomes, can the anatomic goals of eliminating the long-term complications be met with a minimally invasive approach, since the open repair doesn't really work? Next. And then just click on this because we'll go. So when we talk about TBar for acute dissection, this is a cartoon of a dissection here, and you can see the entry tear. Next. And what we do is we put a wire up and advance the stent graft, which is on a catheter. We cover the entry tear. Next. And that, you can see it always happens this way. It seals very nicely and there's no more flow in it. But that's sort of the goal here, is that by sealing that entry tear, we can block flow to the rest of the false lumen and get it to occlude. Next. And so this is, I think, a very interesting patient as we go through here. I might have to, let me just walk and point because it's easier. So this is the aorta coming down. Here's the dissection flap. I like this because you can actually see a fenestration here, which you don't always see. Next. And again, we've got a true lumen that's completely dissociated, and these are the ones that are really dangerous for having malperfusion. Next. And as you get into the visceral segment, this is the true lumen, very little flow there going into the celiac. Next. This is flow into the SMA, again, coming off of the true lumen. Next. And then you can see there's a slit for the renal here on the right side. Next one. And there is flow on the left, but again, it's a problem right there. So keep going. And then this shows that it extends into the iliac. So you can see how these are really complex cases. Next. So the way we treated this is, here we are doing the aortogram. This is the true lumen. It's a very small slit. You can see the false lumen here is this kind of haziness, and it's very large. So we put the stent graft across. Go next. And then you can see afterwards, now there's no flow in the false lumen anymore. There's flow through the true lumen. And the way we do this is we kind of work from the head and go to the toes. So we seal it, and then we'll use intravascular ultrasound to see what needs to be treated next. So go next. We came here, realized that the celiac still had a static stenosis there, and so we put a stent in it. Go next. And I did cut out some of them. Go to the next one, and then we end up putting stents in the iliacs to get things open. So you can see these can be really complex cases as you go through them, but you can end up with really nice results. Next. Okay, so as we look at TBar in the real world, this is a study we did looking at the Medicare database. Click again. And what I wanted to show here is that TBar became available between 2004 and 2005, and you can see that in 2004, only 13% of dissections were being treated with TBar in the Medicare database. Most were treated open. By the time you get to 2007, despite the fact that we didn't have an indication yet, 43% were being treated with TBar versus open, and the number of total dissections being treated had gone up quite a bit. So click again, and I think that, yeah, the mortality associated with this was around 9% versus 20% with open. So you can see why, in the short term, we really wanted to do this. Next. So I think TBar has replaced open repair, especially for patients with the complicated type B aortic dissections. It's clearly the 30-day mortality has been excellent, and it's 10% even in the sickest patients. But medical therapy does remain the gold standard for patients that are uncomplicated, and I'm going to try to make the argument that there is no such thing as an uncomplicated type B dissection. Next. So why do we do medical therapy? Well, the historic data shows that even at 1 year, the patients that are treated with medical therapy have a pretty good survival. It's anywhere from 72 to 90%. And when you consider that you had 30 to 50% mortality with open repair, it was a no-brainer. This is the way to go. Next, but at what cost? So in the chronic phase, you get aneurysmal degeneration over time, and it's been associated with false lumen patency. And it's interesting, I've been quoting this for a while. Long-term progression to aneurysm occurred despite medical therapy in 25 to 40% of patients. And I realized when I look back, this is a DeBakey article from 1965. So we decided it's time to see if the new therapies made a difference. And so next, so this was, we did a series of natural history studies. One is published, one isn't. This is the one that's published. And go to the next one. And so what we did is looked at 826 patients with acute aortic dissection, excluded the type A's and anybody who was managed operatively initially. So you have 298 patients with type B dissections that were managed medically, and we looked at the outcomes through December of 2013. Next. And we looked at endpoints of failure of medical therapy, which was death, or any related intervention. Next. And so here, this is our long-term outcomes. I think you got to click again because an arrow comes in. There it is. So I got these in my head. You can see that 58% of the patients had a failure of some kind with 4 years of follow-up. So that's pretty bad for medical therapy. And there was a 38% mortality rate and a 30% intervention rate. Next. And when you look at interventions, almost all of these were aneurysms. So 65% of them were open repairs for thoracoabdominal aneurysms. So these are big operations with this. And you can see the average time to operation was 2.3 years. Next. And what was interesting, when we superimposed the survival curves, this is starting from the time they initially presented, of the patients who were treated with operative therapy, that's the green, versus patients that were non-operatively treated. By 2 years, they mirror each other, and then they separate. And you can see that patients that had some type of intervention actually had a better survival, while the patients that were treated non-operatively continued to die. And what's interesting is that this has been shown in several other studies as well, as they looked at the IRAD data, and there was an INSTEAD prospective trial that at 5 years showed almost the exact same split at 2 years. So clearly intervening has made a difference for these patients. Next. So then we wanted to see, okay, well, what is the rate of aneurysmal growth? We know that all these patients a lot of these patients are needing intervention, but can we figure out, maybe predict who's going to grow? So go next. It's the same group of patients, but this time we had 200 of them that were medically managed, but we had imaging studies for long-term. Next. And we looked at aortic growth, which was defined as greater than 5 millimeters over the follow-up period. We did exclude 5 patients that had really rapid degeneration because it made the growth periods, we couldn't figure it out. So we got rid of those. Next. And with 5.3 years of follow-up, you can see that 46% of the patients showed growth of some kind, and only 25% had a thrombosed false lumen at the time that they were discharged. Next. And it's interesting, the aortic growth rate occurred in sort of two functions. So click again, hopefully stuff will show up. Yeah, so if they grew greater than 5 millimeters, this was really rapid. They grew at a rate of 24 millimeters per year, and it was all false lumen. You can see 21 millimeters in the false lumen. Yet then we had this other group that didn't grow, click again, and so their false lumens actually got smaller. So I think what we're going to see is that early on there's this group of patients that just grow fast, and then these ones that are growing slowly will probably become aneurysmal 10 to 15 years later. Next. And when we look at freedom from growth, it's pretty dismal here. At 2 years, it's 77%, and at 5 years, it's 51%. So clearly, medical therapy is falling short with these patients. Next. All right, so is TBar the answer? This is sort of the end of what I'm going to talk about. Go to the next one. The thought is that if you can cover the entry tear and you can exclude the false lumen, that maybe you can get the aorta to remodel. And what's remodeling? Well, we want the aorta to heal around the graft, and we see this by expansion of the true lumen, having obliteration of that false lumen, and then having an overall static aortic stability, or at least shrinkage around the stent graft. Next. And so we looked at long-term anatomic changes in the aorta after stenting. Next. And we had 33 patients that we did this. 19 were from an industry-sponsored trial, and 14 were from MGH. And we looked at the long-term anatomic follow-up. Next. Outcomes were pretty good. These are all symptomatic patients, so they all had end organ ischemia of some kind or rupture, and the 30-day mortality was 12%, and 1 year was 24%. Go next. And we had 4-year follow-up for these. And so the maximum aortic diameter between the baseline and 1 year, or 1 month, increased a little bit because of oversizing of the stent graft, but you can see that by 1 year and late follow-up, it really evened out. Next. The true lumen diameter got bigger, as one would expect, because you could see how compromised they are, and then it continued to get larger over time with late follow-up. Next. And then the false lumen diameter got smaller and continued to get smaller, and if you click next, 84% had total false lumen thrombosis or obliteration along the stented segment. Next. We look at the maximum diameter in the unstented segment. It did grow, but it didn't grow much. It was significantly different between the two at 1 month and in late follow-up, but it was a small growth. Next. And the average diameter increase was only 14%. One patient did have significant growth that required a distal extension of a stent graft. Next. And when we looked at the average growth in the visceral segment, I think this is an important thing here. This is looking at patients that had false lumen that were patent versus thrombosed. The yellow is patent and the blue is thrombosed. So if your false lumen was thrombosed, you didn't grow. And if it was patent, it grew quite a bit. Next. So from that data, we found that the 12% mortality was pretty low in the high-risk population, and TBar did promote aortic remodeling. We saw a stabilization of the overall aorta. We saw true lumen expansion, and we saw false lumen shrinkage, and then the unstented aorta, however, continued to enlarge. So I think that means that TBar makes a lot of sense in these patients. The FDA agrees. In October of 2013, they approved the Gore C-tag, and in January of 2014, they approved the Medtronic variant. So we now have 2 stent grafts that have an indication for any dissections. I think the last one here. So in conclusion, these are really your take-homes. The results of treatment have improved with early recognition and management of the critical branch compromise. TBar, I think, is the treatment of choice for patients with complicated dissection, but medically managed patients do not do well. Greater than 50% of them fail over time and would likely benefit from early TBar. The thing now is to determine which of those uncomplicated patients would benefit from it. Thank you.